Honor our brothers.
Dr. Edith, is she there? Can you unmute, please, and say the opening prayer for us? Okay, it seems she's not online. Can Dr. Anne Imoro help us with the opening prayer? Dr. Anne Imoro.
Amen.
Let us pray. Heavenly Father, we thank you. Thank you for all that you've done for us. We are grateful. We are grateful for CPAN. Thank you for the national CPAN and the states and all the specialty groups in CPAN. Thank you for this opportunity to learn from those in diaspora. Thank you, Lord, for this opportunity to improve our practice and our knowledge. Lord God Almighty, we ask for your mercy, we ask for your wisdom, and Lord, we ask for grace. Lord, may we not just be hearers, but also doers of whatever we learn today. In Jesus' mighty name we pray. Amen.
Amen. Thank you, Dr. Anne. For want of time, I would briefly introduce our VIPs present here, just briefly. I want to recognize the presence of the National Chairman of CPAN, Dr. Maureen Wako. You're welcome to this meeting. And all the other National ESCO members here present, you're welcome. I welcome all our fellows of PSN, our fellows of WAPCP, all the elders here present, all our colleagues, you're all welcome to this meeting. Then I want to specially welcome our panel discussants to this meeting. There's noise at the background. Can everybody mute themselves, please? Can we all mute ourselves? Okay, I want to specially recognize the presence of our panel discussants, Dr. Teresa Pounds and her team. You're welcome, and we thank you for agreeing to be part of this discussion with us. Today's topic, we are looking at building a collaborative healthcare practice in Nigeria, the value of consultant pharmacists. With all the challenges we've been having in Nigeria with the acceptance of the consultant pharmacist cadre and the acceptance of our roles in clinical practice, this particular presentation is one that has come at a much needed time for us to educate ourselves, also help our colleagues and even some people who are not pharmacists to understand who the consultant pharmacist is and the role of the consultant pharmacist in different practice areas of the healthcare profession or of the pharmacy profession. So I would want to introduce briefly our lead discussant, Dr. Teresa Pounds. Then she would come on and also introduce her team members. Please, can we mute ourselves? Can we all mute ourselves, please? Okay, Dr. Teresa Isiche Pounds, PharmD, BCNSP, FNAPPSA, FCP Pharm, is a seasoned consultant in clinical pharmacy, nutrition support, and global health. She's the founder of WASPEN and a former president of the Nigerian Association of Pharmacists and Pharmaceutical Scientists in the Americas. She has over 20 years of experience in residency training, teaching, and clinical leadership. She currently serves as the Clinical Assistant Dean at South University and a Consultant Residency Director with WAPCP. She's going to be speaking to us today all the way from America with her team, her special team of five wonderful women who are doing very well in their different practice areas. There's so much to say about her, but because of time, we may not be able to say everything about her. But we all know her, and she has really been a great support system for us, clinical pharmacists in Nigeria and general pharmacists generally in Nigeria. She's in good partnership with us, CPAN, and also in partnership with PSN. So she's always present. She's always available whenever we need her to help us educate our pharmacists and also to mentor our pharmacists. So I use this opportunity to call on Dr. Teresa Pounds to please come on and also introduce your team members.
Thank you so much. I think I would say greetings, since we are afternoon here and everyone is over there. You are in the evening right there. So again, greetings from Atlanta, Georgia. And then we also have some of our people who are here. I'm having an echo here. I'm having an echo here. Let's see. Can you all hear me over there? Can everyone hear me?
Yes, we can.
Okay. It looks like I'm having some echo here. I don't know why. Can your IT person figure out from that end why? Okay, it stopped now, so maybe it was just temporary. So it's really a pleasure to be here today. And thank you for that wonderful introduction, the moderator. Really, I appreciate that. But I want to start first by introducing the members of the team. So I will start with, let me see. Just give me a minute. I will start with Dr. Vivian Lau, because she's next to me on the flyer. What I want to say about Vivian Lau will probably take me all day. So I'm just going to summarize it. And a lot of these people who are here on this panel, I will make it short because I couldn't do what I do today without them, and I want to start by really thanking every one of them for participating in this presentation we're going to do today. What they did really shows how much they want to support what we are doing in Nigeria. I did not give them much time because we know what we are dealing with. So that's why I made this a priority. And because of the relationship and the love they have for what we're doing in Nigeria, they made it also their priority. So I really want to thank them. I want to give kudos to every one of them before we start. And please to thank them. All right. Now, starting with Dr. Vivian Lau. She's interim chair of pharmacy practice at Mercer University. I don't know why I'm having that echo. You'll figure that out. I'm really sorry about this. She's a specialist in critical care, which means she leads regional and national pharmacy education and leadership initiatives. She has authored numerous peer-reviewed articles and currently serves as the president-elect of the Southeast chapter of the Society of Critical Care Medicine. So again, please help me welcome Dr. Vivian Lau. Next to Dr. Vivian Lau, we have Dr. Anisha White. Anisha White, again, you all can see her credentials there. Senior Associate Dean for Strategic Initiatives at the University of North Texas. He has expertise in pharmacoeconomics and health services research. May I suggest that we automatically mute everybody, please? Is that possible? Can somebody please automatically mute everybody? That can be done. Otherwise, it's going to really be it's going to distract a lot of what we're going to do today. I will unmute myself so that anytime anybody who wants to speak can then unmute themselves. I think this is smart.
Now unmute and continue.
Yes, I already did that. So can everybody hear me because I've unmuted myself now? Okay. So going back to Dr. Anisha White, like I said, she has expertise in pharmacoeconomics and health services research. She's a 3-time ISPOR Distinguished Service Award recipient and current president of the AMCP Foundation Board. Dr. White is a nationally recognized educator, mentor, and thought leader in managed care pharmacy. So again, please help me welcome Dr. Anisha White. Thank you. I think we know the next speaker, Mrs. Folashade Lawal. Again, you all can see her credentials. She's a distinguished community pharmacist with over 30 years of experience. She's founder of Victory Drugs and the Victory Vaccine Clinic. She's a passionate advocate for preventive healthcare and health education. She currently serves as vice chair of the Public Health Pharmacists Association of Nigeria and has received numerous national awards for community impact. So again, welcome, Mrs. Folashade Lawal. And the last speaker we have, Dr. Tarite Asogwa, and please, I hope I didn't kill your name. You excuse me. Again, you all can see her credential. She's PharmD. She's a researcher in pharmaceutical health outcomes and policy at the University of Houston. With over a decade of clinical and academic experience, her work bridges research and implementation to improve care delivery, especially in underserved settings. She's a mentor, educator, and policy advocate with leadership roles in CPAN, PSN, WAPCP, and actually, I think she forgot one, which is actually NAPSA. Thank you. I want to welcome everybody. These are our panelists for today. Before we go on, I would like to say a little bit about why I chose this panel, the panelists. I remember a couple of months ago, Mrs. Lawal came to me with a very innovative project that she wanted to be part of that is actually housed here in the United States with ACCP. And I thought that this is really not something I can do, that I want to do by myself, that I've been blessed to know some of these wonderful specialists in US. So I decided to put a group together, and that group, we call that group GPDSA. Now, let me tell you a little bit about that group. We feel that collaboration starts with visibility. That's what this group felt. So we felt we needed to have a visionary think tank of globally trained Nigerian pharmacists collaborating together to elevate pharmacy practice in Nigeria through international expertise, mentorship, and strategic innovation. So what I did was I started with the specialists within US. So that's how I thought of Dr. Vivian Lau, I thought of Dr. Anisha White, because this I don't know, for some of you on this call, probably will remember Dr. Pamela Moye and Dr. What was that? Angela Shobogun, how they came with me to a lot of the clinical programs that I did in Nigeria. And through everything they did, they were able to build up their portfolio, and they had the opportunity to see what was going on in Nigeria, and they gained from what they saw. So I think Dr. Pamela Moyes, what she gained from being part of what's going on, stimulated Dr. Vivian Lau to join us. So that's why they are there. So this group, and then of course, Tari practiced in Nigeria and came over here, and she's very passionate about advancement of clinical pharmacy. So again, that's why I joined her. So at a glance, what we want to do with this group is we want to collaborate, not only with the clinicians in Nigeria, but also try to identify some like minds, Nigerians who are in UK, who are in Canada, and then eventually grow this group whereby we can together continue to work with the great minds like you guys that we have in Nigeria to advance clinical pharmacy practice. So I think that's what I would like to say about that. So again, we're glad to be here. So we can go ahead and talk about what we want to talk about today. Some of the information we're going to share, some of you have probably heard it, but we want this to be collaborative. We want to use the opportunity to applaud what is being done in Nigeria. We also want the opportunity to continue and be part of this journey that I am very, very sure is going to end up a success. So what is our objectives today? The first thing we want to do is describe the role of the consultant pharmacist in advancing collaborative patient-centered care in Nigeria. And I want to focus again on that word, patient-centered care. The next, we would like to compare global and Nigeria pharmacy practice models. We will probably talk more about what's going on here in US, but we will probably allude to what's going on everywhere else, because I've been watching and reading everything that is going on the platform. A lot of you have done, some key people have done a great job in terms of really seeing what's out there. And that's good, because when you're in a situation, it helps to do your homework, find out what's going on elsewhere, so that you know how to use that information to at least better position yourself. So we want to compare, and then of course we want to identify opportunities for clinical integration and teamwork. We also would like to showcase the impact of pharmacy-led interventions through case studies in acute care, community, and public health. And then we would like to explain the need for structured training. Through this discussion, we may be able to bring up maybe some opportunities or gaps. As you all know, nothing is perfect. Even here in the United States and the developed countries, they are still identifying opportunities and gaps, and to kind of see how they can kind of improve. So we're hoping that maybe we can explain the need for structured training and mentorship, including how you can collaborate with the diaspora supported, residency and capacity building, which is actually happening now in Del Sud. And finally, which I think is what I'm hoping will really be a great help, is to propose a roadmap to scale consultant pharmacy roles, focusing on policy, collaboration, and system reform. So that is what we want to talk about today, and we will do our best to make sure that this is done. So before we start, I also want to use the opportunity to thank the CPAN leaders, and I hope Dr. Madhu is here. I want to thank him for really getting the great minds together and what CPAN has done. And of course, my regards and thanks to our current chairperson, Dr. Maureen, that I've known her for years. So I want to thank her for allowing us to come in to have this discussion. So let me go to the first slide. So I think who is going to be I think a great quote to start is actually a quote that the GPDSA, meaning our group, what really is motivating us to do what we do. It says that the greatest value we can offer our patients, and that's why I say let's really focus on that patient-centered care, is when we work together, combining our strengths to create a patient-centered experience that exceeds their expectations. So we believe in this. We believe in patient-centered care. We believe that the patient always should be the focus of everything we do. And I think that's what, if we continue to remember that, that will help everybody. And when you believe in that, and the patient is the focus, then we will recognize that it doesn't take one person to take care of that patient, one person or one discipline. It takes all the disciplines, and that each discipline have some strength, something valuable that they bring into the table. So again, patient-centered care, utilizing all the resources, the strengths that everybody has. So I want to start with that. Next slide. So why does collaboration matter in healthcare? Like I said, some of you probably have seen this. Collaboration healthcare, number one, improves patient outcomes. It also improves safety, efficiency, and satisfaction of the patients and professional satisfaction. When pharmacists work alongside physicians, nurses, dietitians, laboratory scientists, you see, if you then look at outcome measures, you will see definitely decrease in medication errors. You will see that chronic diseases are managed more efficiently. And then when you're looking at transition of care, meaning the patient going from the acute care setting to the community, definitely you will see a great improvement, because the pharmacist or the team in the acute care setting will now work together. They will ensure that all the necessary information that needs to be passed on to the community setting is done. So when you look at some key advantages of having everybody work together, this is a great one to look at. Now, global systems, increasingly, they recognize that pharmacists are core clinical team members. In fact, there was a video that I'll be glad to, maybe I will share that, send it to Dr. Maureen. Maybe some of you have seen it. It was a video, and in that video, a physician made a comment that pharmacists are unrecognized and unsung heroes, that these are disciplines that are really underutilized. And I agree. And I'm sure a lot of you will say that we, the pharmacists, we are unrecognized. Our potential have not been used to the fullest. But the encouraging thing is it continues to improve. It's improving. We will get there. Next slide. Now, if you look at what's happening in Nigeria, in terms of if somebody asked you what is happening in Nigeria in terms of collaboration, this is where it was very interesting when I was preparing for this lecture. It was interesting. Everybody knows about AI, artificial intelligence. It was interesting that I just sent that question to, I use the AI to say, okay, what is actually happening? It was the answers that the various AI, it was the same thing. The point that was made, or the answer that was given, was interprofessional collaborative relationship between doctors and pharmacists in Nigeria remains limited, but progress is being made. All right. Now, he also noted that the current situation of this collaboration between pharmacists and physicians is a complex situation, and that is influenced by many factors. And the factors that were the key thing was that most healthcare institutions still operate under professionally siloed systems, meaning there's still opportunity there. All right. That pharmacists often are not involved in patient care rounds or care planning. I think it's what everybody knows. So that silo mentality is still there. That referral networks between physicians and community pharmacists are still weak, or in some cases, non-existent. So it's interesting. So that tells you now the value of this AI. It's like they know everything that is going on, all right? And when I talked and interviewed some people and talked to people, this was confirmed, that there's no formal framework for collaborative practice agreements like we have in US. That's a big thing that is happening in US, collaborative practice agreements. And what is the implication of all this? The implication is patients are the ones that miss out. So that goes back again to what I was saying about that patient-centered care. If every one of us continue to put the patient as the focus, I think that will continue to help us in this wonderful journey of trying to get to whereby a day will come, we will have pharmacists, physicians, and everyone working alongside each other for the benefit of the patient. So the implication is that the patient miss out. Next slide. Go ahead. So what are the barriers that is limiting collaboration in Nigeria? And what we did was look at the three settings: the hospital setting, community, and then the system. Starting with the hospital. Pharmacists often are excluded from multidisciplinary rounds. That is a fact. If you really do, if we do a survey of what's going on in Nigeria, we will see majority of the hospitals is happening in Del Sud, where WAPCP is has launched the International Pharmacy Practice Residency Program. That is one of the things that we are trying to improve. There's a great improvement there. And WAPCP recognized that this is what they want to move to have it whereby their pharmacists can be more involved in practice, can be more involved in collaborating with other, healthcare providers, the physicians, the nurses. But majority of the hospitals, at least as it is today, and please, I would like anybody to correct me, I think that's still a known fact, that multidisciplinary team is not really happening. There's no structured documentation of EMR access for clinical pharmacists. Yes, that's an improvement with Del Sud. I think that's a system thing, technology, hoping that will also happen. Where that there's a lack of recognition in hospital policies for advanced roles. That's also one of the gaps. Looking at community settings, there's a disconnection from formal referral systems. And I'm sure our speaker from the community setting can probably talk a little bit about that. That pharmacists are undervalued by physicians, we mentioned that, and that we have limited support for public health initiatives like immunization or chronic disease education, having pharmacists involved. Now, as you all know, NAPSA worked with a group, Professor Larry Balley, Dr. Samuel Adekola, a couple of years ago. We came up with a training program, and Queensley was also involved. The training program is still going on now. So a lot of the pharmacists have gone through the training. They all trained to give the vaccinations. But because of what's going on in Nigeria, I'm not even sure how many pharmacists are able to utilize that expertise. So that's just one example right there. Now, what's going on in terms of the systematic challenges? If you look at the salary disparities, it's definitely a known fact. Professional rivalry and lack of mutual respect, I think that's happening. And then we have the minimal interprofessional education, in training institutions. So some opportunity there is improving, but some opportunity. Next slide. Next slide. Now, so if you look at interprofessional collaboration, a global and regional snapshot, for the global perspective, you will see that interprofessional collaboration improves patient outcomes, like we said. That pharmacists contribute to dose optimization, to contribute to medication reconciliation, and transitions of care, chronic disease management, and vaccination outreach. And I will give a little example when it gets to my turn for me to talk, when I'm talking to you guys about the metabolic support, what happened in my institution, and how one specialized clinical pharmacy area, which is nutrition support, my field, how I was able to do that, and then how that opened up the doors for other clinical pharmacy services like pharmacokinetic services, anticoagulation. So you will hear that. So, but definitely, best practices, as you all know, can include clear communication, mutual respect, patient-centered teamwork. And then if you look at what's going on in the sub-Sahara Africa context, the Nigeria studies show that persistent conflicts and communication gaps between professionals are some of all the things that can happen. So the takeaway there will be we need to unlock the full potential of pharmacists. Nigeria must adopt global collaboration models, to the local reality. So go to the next slide, please. I think we need to go. I think now this will lead me to introducing the other speakers. When you start talking about what collaborative practice can look like, I will start by talking about nutrition support. Then Dr. Vivian Lau will talk about critical care. And then community practice, Dr. Vivian Lau will talk about critical care. And then community practice, Dr. Lawal will talk about that. And then for the pharmacovigilance, we'll have Dr. White to talk about that. And then I think Terry is kind of, in terms of the inpatient setting, Terry will talk about that. Next slide. As you all know, my background is nutrition support. A lot of the patients that require specialized nutrition support, a lot of them end up usually in the ICU, meaning intensive care setting or critical care. Some are on the patient care areas like internal medicine wards, oncology, and so on and so forth. As mentioned, I have close to over 20 years of experience in this field. I want to just briefly talk about what a nutrition support specialist pharmacist does. Then I also want to briefly, maybe take 2 or 3 minutes, talk about how did I initiate this in my institution to where it is today, and how what I did with nutrition support helped to open up the doors for the other clinical pharmacy functions. So going back to when I did my residency, my second year, which is my PGY2, which is a specialization, my residency program director was inherited the nutrition support service as a monitoring service, meaning the pharmacist, the dietitian, the nurse, every day they will make rounds in the intensive care unit, look at the patients who are on parenteral nutrition or enteral nutrition, look at the labs, but I'm going to focus more on parenteral nutrition for the purpose of this presentation. And then we will call the physician that is taking care of that patient, and we'll say, oh, this patient is on central parenteral nutrition. The potassium yesterday was 3.0, it was low. Today is still low. Discuss all the labs, and then we say, okay, this is our recommendation. Then the physician would be the one that will then write the parenteral nutrition orders. I had already done my PGY1, meaning I'm already a generalist clinical pharmacist, but I wanted to specialize in nutrition support critical care. So that's why I went ahead and started my PGY2. So I felt like that this has to be changed. I felt like, and I convinced myself that yes, I should be the catalyst for the change. But how did I do that? First of all, I had the passion. I knew that nutrition support is what I want to do, that I want to make a difference in the care and the lives of patients, and that I could do that through nutrition support. And I felt like in order for me to do that, I have to be viewed, I have to be valued by the physicians, by other healthcare members. Okay, how did I do that? I had 1 year for my PGY2. I knew that I had to be confident about what I'm talking about. And in order for me to be confident, I knew I needed to be knowledgeable. So I already had that. I had a very knowledgeable residency program director. I was in a teaching hospital, and I had my preceptors and resources to help me do that. But I also knew that I also have to do some work on my own. I knew there has to be a component, a political component to what I had to do. Advocacy, that I had to start identifying the physicians who were well-known, who were powerful in my institution that I can talk to that will be able to help me achieve my goal. My goal was to have them allow me as a pharmacist to provide the expertise that I have. So it took me almost 3 months to the time I finished my residency to accomplish this. I was there. I put in a lot of hours. I did a lot of reading. Anytime there was a presentation that had to be done, I volunteered, giving presentations to the medical residents, to the surgical residents. I had already identified 3 surgeons, a gastroenterologist, so physicians that I knew could help me. And before I knew it, I was not the one talking up about me. It was them realizing that, oh no, we need to have this service do more. Why is it that they will call us with the labs and we will write the TPN orders when there's a pharmacist that can do this? So at the end, my service was changed from monitoring to consultant service. That means any patient that gets admitted to the hospital, the nurses screen the patients, the dietitians, they do the assessment, the physician that does the diagnosis and so yeah, this patient is malnourished, has a non-functioning gastrointestinal tract, patient needs parenteral nutrition, and they would just say consult, nutrition support service to take on, and we will take on from there. I, as a pharmacist, will write the parenteral nutrition fluid orders. the pharmacy will do the compounding. The nurse taking care of the patient will hand the total parenteral nutrition, and then we will continue to monitor the patient. We will look at the labs every day. Instead of us calling the physician to say, make the changes, I wrote the TPN order, I made the electrolyte changes. We transitioned the patient, talking to the physician. So what I had in mind became a reality. So that was my story. So now, a nutrition support specialist, what do? They are involved in the assessment and planning of what needs to happen with that patient, like I just described. They design the parenteral nutrition formula. They look at the labs. They take the information from the dietitian, the patient's protein needs, caloric needs. They write the TPN orders, write what the electrolytes. They do that. Now, they are involved in the compounding and quality assurance. So they take the order, the pharmacist in the pharmacy compounds the TPN, but as we all know, we have like pre-mixed solutions available now. They are also involved in clinical monitoring and adjustments of the electrolytes, as I just mentioned. They are involved in education and counseling. So if you have a patient who has a non-functioning gastrointestinal, maybe the patient has short gut syndrome, and that patient is stable medically, but it's going to require that parenteral nutrition for a long time. The pharmacist is involved in counseling that patient, the family, to say, you have to continue this parenteral nutrition at home. This is what it's going to look like. This is what, so they are involved in that. In prescribing, so typically nutrition support, like I just described it, we had the prescribing authority. We were able to write the parenteral nutrition formula, and every day we were making the changes. Also, that specialist is involved in research and protocol development. So going back to my institution, what I did years ago, what happened after that? Because of what I was able to do with nutrition support, it opened up the doors for them to say, pharmacists are also valuable when it comes to pharmacokinetic, looking at the medications these patients are on, like vancomycin, aminoglycosides. So that led to pharmacy-managed pharmacokinetic service in my institution. And then guess what had happened after that? That led to anticoagulation managed. So one person, God gave me that opportunity. I was able to use nutrition support, not only to help our patients, but also to let the physicians see that there's a whole lot that pharmacists can do that they were not seeing. So next slide, please. Next slide. And these are just, some organizations, in case anybody wants to know the organizations that are involved for nutrition support. And WASPEN does that a lot. Some of you may even be members of WASPEN, so this is something if you want to kind of look at. Next slide. So this summarizes everything I just talked about in terms of the pharmacist's role in parenteral nutrition. So this is again, any one of you who want to, but I think I said pretty much everything. Next slide. So now I would like to introduce Dr. Vivian Lau, who will then talk to us about U.S. acute care experience. So Vivian, over.
Thank you so much, Dr. Pounds, for setting our discussion up. And thank you so much for having me on this panel. And I'm so happy to be here. I'm really excited to share my experience in the US in the critical care space, to see where clinical pharmacy and where the pharmacy profession has gone, and also some of the things that we're currently still addressing. Next slide, please. So I want to start to talk about what clinical pharmacy is. The American College of Clinical Pharmacy defines clinical pharmacy in 4 main areas, and that is application of specialized knowledge, And if you see here, it is beyond medication. So this is just general health and wellness and disease prevention in terms of providing recommendations. So we want to promote health and wellness even before we need to use medication. So general non-pharmacologic interventions. Even though we are the experts in how to use medications, we all know that we don't want to use medications if we don't have to. And so by knowing when to use medications and how to use medications, we can provide patient care and impact patient care to make the outcomes that are the most effective. And so by doing that, we will evaluate and see how we can optimize our drug therapy. When we need to use medications, we're the drug experts to promote safe, appropriate, and cost-effective use of the medications. So by doing this, we're assuming accountability and responsibilities. So although I am focused on critical care, this definition can apply to all clinical and all practice settings, so whether inpatient or outpatient. And then the last component of this is the research part. Not only are we practicing and making patient care better today, but we also want to know what information can we obtain for future health and to improve the quality of life. So now that we've discussed what clinical pharmacy is, what exactly do clinical pharmacists do? So Dr. Pounds made a great point in terms of how that looks like in the metabolic support realm, but it involves evaluation of therapy. So if medications are involved, are we meeting the patient's needs? Are we addressing the goals of care? And if so, is this medication appropriate and does it work? Again, the role of pharmacy for clinical pharmacy is not just to think about the problems that we're currently addressing, but also trying to recognize and anticipate untreated conditions. So maybe they need a treatment for asthma or some other condition, but it's not currently being addressed right now. So it's recognizing untreated conditions. We also want to make sure we're monitoring. So when we recommend or initiate therapy, we want to make sure we're monitoring for potential adverse effects and also making sure that it works. Is it efficacious? And we do all of this in collaboration with other healthcare providers. So this is not an isolated incident. We don't operate independently, but we really are a part of a team with patient education, again, general education on disease and health. And then also when we know that patients need additional support, we can collaborate to help refer patients to additional support or services. All right, next slide, please. So in the US, there's been extensive research papers and just research in terms of what evidence for clinical pharmacy services are there to show that we can make a difference. And so there's evidence to suggest that when pharmacists are involved as members in a collaborative team, that patients do better. Patients often are more satisfied with the care that they're getting. And overall, that can save money. So that reduces healthcare costs. And what this looks like, again, it's related to pharmacotherapy monitoring. So again, looking to see if the medication works, if the patient is experiencing side effects. Oftentimes this can be specific drug-related or drug classes. So are there certain medications that are considered high risk that we want to monitor more closely? We also have evidence to suggest that focusing on specific disease states can help. So whether that would be hypertension, diabetes, different disease state management services are other areas where there's evidence to suggest that pharmacists can make a difference and be impactful. So now that we talk about what clinical pharmacy is, what they do, and what it means, or what value that looks like, I want to shift gears a little bit to show how you can become a clinical pharmacist in the United States, or just through different pathways. So the most common way is a structured formal postgraduate training. Dr. Pounds referred to her experience with postgraduate training, and there is completion of a residency, which is often patient care related, and that can be 1 to 2 years long, but that's not the only way. There are fellowships that you can pursue. There's also graduate studies, if that is of interest, and I'll kind of share more about what residency training looks like, because often for clinical pharmacy, residency training is the most direct way to become a clinical pharmacist in an inpatient setting. But there are other pathways, so traineeships, like, certificate programs, there are different practice-based activities. So again, these often are offered by various organizations that you can look at, and they focus on specific areas. So there could be a critical care traineeship, which is not as long as a residency, but it's a very specific focus area, and it's usually a few months to 6 months, and there's typically a self-study component with the traineeships. There are also practice-based activities. So there are courses that offer certificate programs. So if you're trying to increase your skill set, there are certificate programs that you can consider. So immunization courses are a common example. There could be, opioid, naloxone training, different types of certificate programs that are practice-based. And you can also obtain board certification, and that's the professional competency piece. So the other pathways that you obtain can all qualify for professional competency, and that's also another way to just demonstrate the extensive training that you have. And even after you obtain your professional certification, you still have to maintain your continuing education to demonstrate that you're specialized in this area and you continue to practice and you are the expert in this area. Next slide, please. And so again, I want to focus on postgraduate programs, but please know again that that's not the only way that you can become a clinical pharmacist. But postgraduate programs are accredited by the American Society of Health System Pharmacy, and they establish standards that each program has to meet in order to receive accreditation. But again, this is the most direct way, but it's not the only way. So typically with a postgraduate training program, there are 2 years, so PGY1, which stands for postgraduate year 1, and PGY2, which is a postgraduate year 2, which is often a specialty residency. So anyone can complete a PGY1 residency in various areas. We're going to focus on the institutional or pharmacy practice one because that is related to the acute care side, but there are community pharmacies, there are managed care residencies, and after you finish a PGY1 year, you can specialize in a second year. So Dr. Pounds completed one. My area is in critical care, but again, there are a variety of specialties that you can complete to pick your area. Now, the fellowships are typically more research-based. There's the best-known fellowships are often the industry fellowships, but there are academic fellowships and there are pharmacokinetics fellowships and different outcomes-based fellowships that you can complete as a part of that postgraduate training. Next slide, please. So I want to emphasize that residency training is valued and important. Various professional organizations in the United States want residency training to become the standard and the norm. So the American College of Clinical Pharmacy, or ACCP, recommends that by 2020, residency training should be a prerequisite for entry into pharmacy practice. And then the Joint Commission of Pharmacy Practitioners, which is a group of, it's an organization that is endorsed by multiple various professional pharmacy organizations. They also have a belief that again, to advance pharmacy training, that pharmacists should have the authority and autonomy to manage medication therapy and be accountable for patients' therapeutic outcomes. So, of course, obviously, we know this is 2025, and that residency training to be a prerequisite for entry into pharmacy practice as a requirement has not happened. But again, that was something that ACCP wanted. And of course, this is something we are still working through now, even in the United States, because it's not required, but it is a goal for residency training to happen for pharmacists as they finish their pharmacy education. Next slide, please. So now I want to shift gears to specifically talk about critical care pharmacy services in the United States. So critical care pharmacy services in the United States has been around for a long time. It's probably one of the first specialties that was created, and where pharmacists work collaboratively with physicians and nurses and other healthcare providers to promote patient care services. So in the ICU, intensive care unit, our patients are very sick, and there are a lot of things happening at the same time. And so the pharmacists in the critical care area, they have moved beyond just merely a dispensing role, and they're really focused on a patient care role. So in the 2000s, there was, I think it was the year 2000, there was a position paper that came out to describe some recommendations about what pharmacists should be doing in the United States. And then in 2020, the most recent update to that, because it was 20 years since that position paper was updated, in 2020, they came out with, they revised and added more recommendations for a total of 82 recommendations covering the 5 domains of core and desirable services for critical care pharmacy. So if you're interested, I put the link on there, but the 5 domains are related to patient care, quality improvement, research and scholarship, training and education, and professional development. So if you look at these core elements, and then you think back to a few slides ago when I talk about clinical pharmacy, you can see that these overlap and are very much aligned with what ACCP's definition of clinical pharmacy is. So not only are we providing the patient care, but what are we doing to make things better for the future? And that's the research and scholarship, and then the training and education. And so in 2021, there was a survey that was published that characterized what clinical pharmacists in critical care are doing across the United States. So this was a 27-question survey that was sent out to, that had over 1,000 hospitals in the United States. And this was some of the main areas based off of the results of this survey. So I'll describe that in the next couple of slides. So based on these responses, pharmacists in the United States are participating with physicians and other prescribers in direct patient care rounds. So that is a main role. And based on this, pharmacists can order medications independently based on collaborative practice agreements, which Dr. White will talk about later on, or a hospital protocol, which is a standard operating procedure. So even though they're working as a team, pharmacists have the authority to order medications and other labs, just like Dr. Pounds described with the metabolic support team, based on their assessment and evaluation of the patient. Another thing that pharmacists do in the United States in critical care, they are continually reviewing the medication history for patients who are coming into the ICU from either the floor or coming in from a new hospital, and they're performing medication reconciliation at transfer. So that could be transfer out of the ICU to another facility, or just transferring to a lower level of care. So there is a continuous process with, people coming in and people coming out. In addition to that, we are responsible for various consults and documentation of the consults. So nutrition support is a great example. Another one I want to highlight is the therapeutic drug monitoring piece. So this is where we focus specifically on drugs that are high risk, or they need close monitoring because there is a narrow therapeutic index for the drug. So vancomycin, aminoglycosides, these are some examples of infectious diseases drugs that will need close therapeutic drug monitoring. So within these protocols, the pharmacist will assess anybody who starts a medication to determine what dose, and then how to adjust the medications. And then also they will be able to adjust it and also recommend to discontinue the medication if they believe that therapy can be completed. So again, keep in mind, this is in collaboration with a team. They're not working independently, but they can assess and evaluate and to provide their recommendations as part of the healthcare team. Another main role that pharmacists play in the critical care world is with emergency efforts. So pharmacists participate in resuscitation efforts, and they're trained in advanced cardiac life support. And so they are responding to resuscitation efforts with cardiac arrest or any emergent situations. Some hospitals will have pharmacists respond to stroke alerts to help with administering TPA or certain medications that are time sensitive. And then at major trauma centers, pharmacists are a big part of the trauma team. And so they are involved with trauma support, whether that's, with intubation or some of the pain assessments, pain medications. Those are other ways that pharmacists have a big role in the critical care world. And then, of course, another one is just drug therapy related education. So oftentimes we have providers who are unfamiliar with some of the literature related to some of the medications that are used. And sometimes this could be for families and caregivers as they transfer. Next slide, please. I want to keep going just also to continue with the role of the pharmacist. So pharmacists, as they're reviewing the medication and they're the patient's history, they're looking at the labs, they're also making independent assessments on delirium, which is a situation that occurs for patients who have been in the ICU for a long time. They can develop delirium. We also will assess their pain just to make sure that we're addressing patient's comfort level. And after these evaluations and assessments, the pharmacist is a big player in medication decisions as it relates to the selection of the drug, dosing, and then how we optimize. So I've listed some examples here as far as what programs pharmacists are affiliated with medication decisions. So a big one is related to antimicrobial stewardship. So as we know, if medications aren't used appropriately, then that can lead to increased drug resistance, and it also makes the problem harder to treat down the line. So pharmacists play a big role as far as selecting the right antibiotics and then optimizing the dose, because they really don't want resistance for the hospital and also for the patient. Another area that critical care pharmacists play a big role in is related to anticoagulation. So we monitor the anticoagulation for patients in the hospital or maybe patients coming in for cardiac surgery. And we're also involved in decisions as far as blood products like factor products. And this is related to anticoagulation reversal agents. So we have emergent bleeds like intracranial hemorrhage or some of these urgent need for reversal of the products. We will help with the dosing, making sure that they obtain the medications and that the nurses know how to administer and how to make sure that they give the right dose. Because this is also another area where medication errors can happen because of just unfamiliarity with factor products. And then a couple other things is related to hemodynamic support. So as many of the medications related to maintaining blood pressure, they are titratable drips. So pharmacists play a big role to make sure that the drips are running at the rate that is supposed to run. And also related to renal replacement strategies. So when you have patients on intermittent dialysis or continuous renal replacement therapies, that we are part of the drug dosing and making sure that those dosing and selections, those are appropriate. Next slide, please. Now, I know I went through a lot in a short period of time, but I'm really excited and I'm passionate to share about the roles that pharmacists play in critical care. And this slide just highlights the fact that pharmacists can make a big difference in critical care, because there's evidence to suggest, again, pharmacists' involvement in these activities have high impact and high value. Patients have less mortality, which is very important. They stay less days in the hospital, or specifically in the ICU, which also means more money saved. And patients have less drug adverse effects because pharmacists are continuing to monitor and review their medication regimen. So all of that to say that we have a big difference. We make a big difference in the ICU, and this is an area where pharmacists are members of the healthcare team. So again, these are just some examples of what we do in the United States. And then I'm going to transition next to Mrs. Lawal, who's going to talk about community pharmacy practice in Nigeria.
Thank you. Good evening, everyone. I hope I'm being heard. Thank you, Dr. Pants, for your mentorship over the years and the opportunity I have today to talk about collaboration in community pharmacy in Nigeria, my experience in practice. I will try to be as brief as possible, and I'll be sharing with us my experience that has spanned almost 40 years now. So when I left school, I didn't know the word collaboration in practice. It's not anything that ever occurred to me. So we started with just dispensing prescriptions as they came our way. And because we knew that we should not dispense certain prescriptions without, certain drugs without prescription, and then patients needed to see physicians. We were referring patients to physicians either verbally, or we just picked a piece of paper, write something for them to go. And then gradually too, it became very necessary to document patient experience in terms of their records, because the aim was to help the patient as much as possible. So when patients came and they brought their prescriptions, many of them were not even willing to give it. So we had to look for a way to start documenting, bought notebooks, would write the prescription, give them a number, and when they came back, we'll look at that number, and we started building up on what could we do for the patients. So we also graduated to, okay, patients, because there are times that they had challenges, medical conditions that we could not address or diagnose. And it was important to share their information with physicians or other healthcare professionals. So we also developed patients giving us consent to share their information. Next slide. Next slide, please. So we had a lot of challenges in the early stages, and we still have quite some challenges. Because we would not sell prescription drugs without prescription, it became important or necessary to generate prescriptions for prescription medicines. And the prescriptions could only come from those authorized to prescribe. So it became important or compelling to penetrate them, to reach them, to make them generate prescriptions appropriately for the patients. So we started forming relationships with prescribers, referring patients to them, and following up on the patients. It was also important for us to help the patients understand their medical conditions. And many patients were not even told what their medical conditions were, or probably might have forgotten, and they will come to us. So it was also important now, it became more compelling to reach the prescribers for the conditions that were being treated for these patients. Now, we also needed to help the patients to access optimal health care. And that means that their drug therapy had to relate properly with whatever their medical condition was. It was important to ensure that the right drug, the right diagnosis, and all that. We needed to help the patients to prevent disease or deterioration of their condition. So I was compelled in my early years of practice to seek knowledge. I was compelled to make friends with those who are managing the patients so that we could help the patient optimally. So the patient was at the center of that care. All we wanted to do was, what could we do for this patient? So we had to reach out to other healthcare professionals. We had to look for a way to endear ourselves to them, to get information related to the patients. We educated the patients on the need to involve us in their care. And some of them would just insist. They would request it, and they will say, look, this is my pharmacist. I want you to carry along with my management. And that's where we were making friends. It got to a stage that it was more or less like reciprocal, because some physicians also came to us to say, how can we work together? How can we share patients? Can you refer patients to us? Because many patients will come to us to say, I know my condition, you may not be able to prescribe, but I need you to refer me to somebody that can manage this condition well for me. So we became like a bridge now between the patients and the other healthcare professionals. Sometimes it could be that they needed physiotherapists, they could need nutritionists, whatever care that they needed. So gradually, we started collaborating without understanding that what we were doing was collaboration. Next slide. Now, to help me do better and care more for my patients, I had to join many organizations then. I joined International Network on National Use of Drugs. I joined the International Society of Pharmacovigilance. I joined we had the Consultant Pharmacist Forum then, manned by pharmacists. I will remember now, remind me. So I joined them and we're doing quite some work. I was just seeking knowledge. I was seeking information that will help me do better with the patients. Because many patients, in the Nigerian setting, access to care, healthcare, it's even better now. It was really bad those days. And many people did not even know what their conditions were. They didn't know what the drugs were doing to them. They were just using drugs anyhow. So it was important for us to help them to understand so that they could take ownership of their conditions and management. I also had to join the Society for the Study of Pain, Nigeria, and attended quite a number of trainings just in a bid to help the patient. Where I'm going is that for me, my driving force all the while has been the patient. What can I do to help the patients better? How can I connect them to the right kind of care? How can I help them to understand what their conditions are? How can I ensure that they're not just taking medications that they didn't need? How can I help them to adhere to therapy? And to do that, it cannot be done in silos. It's not possible. We just have to network with other healthcare professionals. So we started building bridges. Next slide. And about 11 years ago, we came up with this referral booklet. And the thought behind it, it was a whole book. The thought behind it was a communication book owned by the patients between all the healthcare providers, among all the healthcare providers. So what we did, we empowered our patients to own this medical diary. And we told them that anywhere they went for care, they should just ask the person, whoever was prescribing anything, to write in this book so that whenever they came, we reviewed everything with them to help them to understand. Because some of them were just becoming dumping grants for different kinds of medicines. They will see this person, see that person, and their care was disjointed, prescriptions were anyhow. And the patients loved it. They were happier because we were not able to help them to promote rational use of medicines. We helped them to save a lot of money and costs. And it also made us interact with their other healthcare professionals. So this was a concept that we came with. That was 11 years ago, to mark our 25th anniversary, because now we are 36 years old. So I can't remember exactly the year now. It's about 11 years ago. Then we also came up, I had the opportunity then to be chairman of Drug Information Center. Next slide. So we came up with a referral booklet. And I'll tell you a little bit about the issue of the referral booklet. Then we started involving other healthcare professionals in our seminars. We was trying to see how we could work together with them. And I recall someone once said they needed us to be able to document whatever we're doing. So we came up with this referral booklet. And by the grace of God, I still use it. One thing about this referral booklet, this referral form, is that it is accepted. There's nowhere we have sent this form that it was rejected, including tertiary institutions. When we fill it for our patients and we refer, it is accepted because it bears that Association of Consultant Pharmacists of Nigeria. So this is a strength that we need to build on in practice. And it's a bridge. I just wish that we can do more with this referral booklets. We also made prescription pads because we had a few prescribers say, well, they didn't have prescription pads. So we would include, after filling this, we would include prescription pads. And this made it easier for us to get feedback. We had it in triplicates. So we will fill the patient details and we left a column for the physician or whoever we're referring to fill. So they will give us feedback. And sometimes they would even turn to the back to write on it. Some of them would, I had this nephrologist, he would tell us what the goals were for the patient. He would tell us, look, we want the blood sugar to be within so range, the blood pressure to be this and that. And then it would also tell us what his diagnosis was. So we're co-managing the patients. What was lacking was that collaborative practice agreement. Most of what we did were more or less informal or semi-formal. I would say it's semi-formal because we had these documents in between, but we didn't have any agreement to define precisely what each person's role would be in the management of the patient. But we understood to a level what our roles were. We knew that as pharmacists were focusing on the drug therapy for the patient. We looked out for drug therapy problems, and anytime we identified any, we were free to talk to the prescriber to say, we noticed this and that, and we thought to alert you. And then the prescriber would either explain what was happening. Sometimes the prescriber could be justified, or the prescriber would say, okay, now don't worry, go along with what you have suggested. So we've been able to break barriers And our collaboration has been a lot. We've collaborated with an NGO that was sponsoring children with congenital heart disease, pulmonary hypertension, and then we compounded their drugs for them because we have a compounding unit. So the prescriptions will come from the consultants managing them, and we did the compounding, and we were relating together like that. Next slide. Next slide, please. I will briefly talk about opportunities for collaboration, and I have grouped them into intra and inter. Intra meaning amongst us as pharmacists, and we need to collaborate between hospital and community pharmacists. Many times we get patients that have been on admission in the hospital. They're discharged into the community, and a number of them don't even understand their medication therapy. I recall a patient that when she came, she said she was told that she had a bad heart. That was what she could say. She had a prescription for warfarin. She was on dapagliflozin. She was on Varsutan. She was on metformin. I asked her to bring her drugs. I found out that she was taking metformin. She was taking glucophage because while on admission, they were giving her glucophage. She was given a prescription for metformin on discharge. She bought the metformin and added it. And because she had financial constraints, she said when she ran out of dapagliflozin, she now doubled the dose of her Varsutan to make up for. So that is disjointed care. And we did not even understand what our current therapy was because the prescription she was given apparently was for the drugs that she did not have at that point. She did not know what her current therapy was. So we had to look for a way to reach out to the hospital, which was a government hospital where she was managed, so that we could now manage her better. We could get our records, and it's usually very difficult. So I will also talk here that we need to collaborate among ourselves. There should be a way that hospital pharmacists can collaborate with community pharmacists, and they will co-manage the patient. And a number of times, hospital pharmacists have been very helpful to us when we detect drug therapy problems. We go through them to resolve it. So sometimes we just look for the pharmacists we know in that facility, call the pharmacist to say, this is what our challenges are. And then the pharmacist will look for the prescriber and get back to us. And that is good. Then interprofessional collaboration, there are many opportunities between pharmacists and GPs, pharmacists and nutritionists, pharmacists and other specialists. Too many to list here. We collaborate with physiotherapists, we collaborate even with the community itself. There are sometimes that we do outreaches. For example, when we had World Hepatitis Day, the community head came to us to see what we could do to help in screening the community for hepatitis and giving vaccine. So we collaborated, we gave them a bulk discount and were able to do that. So there's a lot of opportunity for collaboration, but we need to be able to formalize them. We need to be able to have documentations. We need to be able to have agreements that will back all of them up. Next slide. So here I have a list of formal collaboration that we do, establishing collaborative practice agreement with physicians. We're at that level now by God's grace. Define roles for managing high risk hypertensive patients. That's what we're doing under the collaborative practice agreement that we're working on right now. We're also looking at cardiology-supported pharmacist intervention. We are looking at targeting complex patients' cases to build trust and demonstrate impact. So what we have done is to start with something simple. Let's look at the hypertensive patients. So we are working to sign a collaborative practice agreement with a cardiologist to say, this is what we can. We've been working together over the years anyway, so we just want to formalize it. And I have quite a lot and a lot and a lot, but I'm trying to squeeze everything because of time constraints. So I'll just give a case study that happened not too long ago. Let's look at that case study. Next slide. Next slide. Next slide, please. Am I being heard? Okay. So, yeah, this is an intervention we made in hypertension. A patient, a male patient, 35 with BMI 34, came in, and the blood pressure was well over 240 millimeters of mercury. The patient had tachycardia, and patient said he had been on methyl dopa, nifedipine, and amlodipine. He confessed to poor adherence, but why would he be on nifedipine and amlodipine? So we wanted to refer this patient to a physician because of the very high blood pressure. So we called the physician, and the physician said we agreed that we needed to, first of all, change that drug. So the physician advised that we did nifedipine 30 milligrams instead of 20, and give 10 milligrams lisinopril and the methyl dopa to the patient.
Did she get disconnected?
I was wondering too. I thought I was the only one not hearing her anymore.
I think it must be network thing.
Okay, so probably while we wait for her, I don't know, maybe
I
the
think,
next speaker can come on.
yeah, I think that's what we
Yeah.
should do. That's a good idea.
Yes, ma'am.
And I think the next speaker, Terry, is that you or
Dr.
Dr.
White.
White? Okay, Dr. White.
Speaking next, yes. I can start. I think it's the next slide, the 2 slides.
There we go.
Yes. All right. Hello, everyone. I'm so grateful to be here today to continue discussing on this topic. Dr. Wow, Dr. Pounds, Dr. Lau have been emphasizing the importance of collaboration. And so I'm going to talk a little bit about collaborative healthcare agreements and then also how those can enhance pharmacovigilance and medication safety. All right, next slide, please. So as Dr. Wow mentioned, she emphasized that collaboration is important to improve care. And what we're going to share here today are some details on how we can formally collaborate. Collaborative healthcare agreements are formal agreements between pharmacists and physicians, as well as other professionals, and it will allow pharmacists to provide expanded services. So as we've been talking about initiating therapy, modifying drug regimens, monitoring drug therapy. These agreements, we would come together with physicians and other professionals to develop the agreements and then develop a team-based approach. So it's very detailed documents signed by all parties, and it gives us a level playing field and allows each of us to contribute based on our strengths. Next slide, please. Now, we've been talking about collaborative healthcare agreements for a while, our sub-team, but as we discuss this more with you all, one of the things that came up is that we want to emphasize that these agreements are not about us replacing physicians. It's more about us complementing their work. And so, as everyone has been mentioning here today, we all have a unique skill set as pharmacists. But when we come together with physicians and with other professionals, we can truly make a safer environment for the patient. We can increase access for the patient and, of course, increase patient outcomes. All right, next slide, please. So I wanted to point out some of the stakeholders in a collaborative healthcare agreement. Of course, we've been talking about physicians, pharmacists, but we don't want to forget the healthcare system as a whole. Collaborative healthcare agreements have been shown to save in terms of costs. They've also been shown to increase the value of care. And so thinking about the clinical outcomes of patients improving, the economic outcomes, of course, in terms of the healthcare system, and also what we call humanistic outcomes. So patient satisfaction, affordability of medications. We've already talked about patient access. These kinds of agreements really help us to make that happen. All right, next slide, please. Now, of course, we can get excited about collaborative healthcare agreements, and you're going to hear a lot of that from us. But we've also been thinking about what can be some of the roadblocks as we go forward. What can be some of our major challenges? They have been identified in about 5 areas. There are regulatory barriers, of course, in terms of standardizing these agreements. So if we have a key template, it would be good if we aim to standardize that across different settings. Physician hesitancy, we've already talked about how our overall goal is to complement the work of physicians, to collaborate towards better care, but we definitely want to emphasize that throughout. Reimbursement. And so we're going to talk in a little bit about what the U.S. is doing with regard to pharmacist reimbursement for these specialized services. But we might want to think about that in our case too here. Do we want to design something where we can have pharmacists to participate in the billing system for services? And then lastly, training gaps. And so in a little bit, we're going to talk about how other professions have expanded their scope of practice, whether it be nurse practitioners or physician assistants in the United States. There was a strategic approach that they used for that expansion, and the key factor was education and training. And so whether it's highlighting your education and training to a physician, to the patient, helping them to understand the comprehensiveness of medication review and the skill set that pharmacists can bring to the table, training helps to highlight that. So we're going to talk about some options for more training and also how to do that alongside physicians. Okay, next slide, please. So overcoming challenges, I've kind of already mentioned this, but standardization, interprofessional education. So some of our training will be within our pharmacist groups, but also in interdisciplinary groups with training. And then knowing that we need to make these steps one at a time, step by step, celebrating the small wins, always putting the patient first. And again, starting with that training and education, I think will be key to us progressing and expanding pharmacist roles. Okay, and next slide, please. So I want to talk just for a minute about pharmacovigilance. We know that pharmacovigilance is so important and plays such a critical role in infectious disease, managing chronic diseases. But in the aspect of collaborative healthcare agreements, pharmacovigilance would allow for an even more structured collaboration towards those types of surveillance and monitoring for adverse drug reactions. It would also allow us to possibly develop databases for tracking medication safety. We might think about post-marketing surveillance, conducting research, We may even think about how pharmacovigilance under a collaborative healthcare agreement may impact regulatory decisions, label changes, and even drug withdrawals. So a lot of opportunities there to enhance pharmacovigilance if we were to partner that with a collaborative healthcare agreement. All right, and then the next slide is on medication safety. This is something else that I think collaborative healthcare agreements can help to amplify. We often talk about how pharmacists can provide comprehensive medication reviews. You know, we can monitor and make real-time therapy adjustments, but structuring that and making that more formal in a collaborative healthcare agreement really does give us that opportunity to communicate our impact as pharmacists to the broader community, whether it be, again, physicians or patients. And then it allows us to perhaps target high-risk populations or special needs populations in a more structured way. So many, many, many opportunities for advancement in our scope of practice. And I'm going to talk a little bit more about some examples later, but just wanted to highlight that this is such a great opportunity for us to forge into the future with regard to the ability of pharmacists to really make a difference. All right, thank you.
Very good.
Thank you.
Very good. So the next person is Dr. Terry.
Dr. Pounds, I think Pharmacist Lawal is back. I don't know if she would just round up before Dr. Tari.
Yes, we can do
Okay,
that.
sure. Is she still all right? That's a good
Yeah.
idea. Thank you.
She's back.
Okay. So, Pharmacist Lawal, I see you back. So, we know you had the network. So, if you can round up, then Dr. Terry will go after you. Is she still on? Hmm.
She's still on, but she's still muted. So if she's not ready, maybe Dr. Tari can.
Okay.
Just
All
give
right.
her a minute. Maybe she's not aware she's muted.
Yes.
Let me text her and tell her. I hope she will look at her.
Or can you unmute her as a host,
No,
Dr. Biajan?
I don't think so. Terry, I would suggest you go ahead and get started.
Okay.
She only has 1 or 2 more slides. Yeah.
Okay.
Thank you.
Okay, thank you so very much for this opportunity. I want to especially thank Dr. Pounds for carrying me really on her wings, all the way. I'd met her first during the Special PharmD training program at Uniben, and since then she's been very, very helpful to my career and brought me into this wonderful group for which I am super grateful. I am going to be talking about the dual training insights, being someone who had been trained in Nigeria and practiced for not a little bit, for a decade actually, before coming here for my graduate program, which I am rounding up. I felt it was a great opportunity to share what differences I've noticed in terms of the academic training, and also share some practice insights from the inpatient setting from Nigeria. So really what I want to do is to see how the healthcare cultures, the bridges that we can build, which is what the whole collaboration is all about, what we can borrow from the people who have been there, done that in terms of collaboration in pharmacy practice. So I have been a TA, meaning teaching assistant for the PharmD program, which gave me for about 4 years now. which gave me quite a little bit of exposure to what is being done in the US pharmacy training. And it was quite interesting to, see that there is really no difference per se in terms of the content of what the US trained pharmacists get and what we get. But what I got to understand is that it's in the way the program is being structured, one, and in the way that the skills sets that are being developed on the students are communicated and demonstrated. So I wanted to say here that there are challenges everywhere. And I'm sure, based on all what the other speakers have mentioned, especially what Dr. White talked about, like people transited from being in this whole state of not collaborating up until collaboration. Even in the US, in the UK, they all had histories of struggle. And up till this time, there are still areas where people are still struggling. For example, this is a paper that we carried out this survey, and some of you in CPAN really helped to help us get data from Nigeria in my first year. So we were really looking at the barriers and facilitators to adverse drug reaction reporting by hospital pharmacists. We're comparing Nigeria and US to see what the challenges were, because globally there is a gap in terms of reporting of adverse drug reaction. And like Dr. White had mentioned, pharmacovigilance is a great opportunity also for the pharmacists to showcase the skill sets that they have built over the years. And interestingly, in this paper, we could see that the pharmacists in Nigeria and the pharmacists in the US all had issues reporting. However, the barriers that were encountered were really unique to each system. I just brought this up to highlight the fact that system barriers are normal, and all we're going to be saying here is not from a place of judgment or what you should do or not do, but just from a place of understanding what is the uniqueness of our own barriers so that we'll be able to work out modalities to overcome them. So I want to pause to talk a little bit. Sorry, I'm looking up because the screen is being shared on another screen. I want to pause here to talk about how I had broken through in a non-collaborative culture. I used to practice at the University of Port Harcourt, and a new unit was created. That unit had the oncology unit, the drug rehabilitation unit, and the geriatric unit. So all of these units were sharing a building in the University of Port Harcourt Teaching Hospital, which wasn't attached to the normal hospital building. And when I went there, I was to start the new pharmacy. There was no pharmacy there because it was a new development. And I felt it was an opportunity really to showcase who the pharmacist, the clinical pharmacist really was. And I was grateful that God had given me that opportunity to showcase that. And I wanted to share a little bit of what we did. So what I did, really, which is what anybody can do in any practice setting, was to start with the lowest hanging fruit. What do I know? I am the drug expert, and I'll be able to identify drug therapy problems. And coincidentally, that was when I was doing the Special PharmD conversion program. And even if somewhere in my heart, I had always wanted to do more, like I didn't go to school for 5 years just to dispense pills, right? So, but I didn't know how to. But thankfully, Dr. Pounds and her team, in collaboration with PSN and Unipen, brought that program, and it was, I would call it a game changer in my practice, because they gave us a structured way on how to go about these things, which I was really excited to incorporate into my practice. And thankfully, I got that opportunity. Everything just happened timely. So what I did, of course, there was no established collaborative culture there. Those who know that hospital know that it is somehow even anti-collaboration. And we will understand as we move further why these people are resistant to collaboration. So remember, there was no collaborative practice. So when I went, I had to put myself into the collaboration, like in the midst of the ward rounds, and contributed meaningfully in such a way that it was obvious that the pharmacists had more to offer. And that way, I remember the consultant psychiatrics, the first day I had gone on a round with them, I had to introduce myself like I'm the new pharmacist posted here and all that. And there were some recommendations that they were trying to provide for the patient. And I was like, oh, what if we use these instead of these? Because this drug has a side effect of drowsiness so that he can still be active. And it was like, oh, yeah. And, like 2 to 3 other recommendations that were meaningful, and they accepted it graciously, thankfully. And that was the beginning of the collaborative practice, like how I broke in. It was just not informal, just going there, like seeing what they were doing and, providing recommendations that were meaningful and were accepted. So over time, I did that a lot with the geriatric people. There were times where medication therapy, drug therapy problems were resolved by myself and my team. And there was like an immediate, obvious impact that was seen, like this blood pressure wasn't being controlled, but immediately you did some changes in terms of moving this drug to morning based on their pharmacokinetic properties and all that, and moving this to the evening. This patient started being under control, the patient's blood pressure. So that really helped the pharmacists to build trust, through making these consistent and useful recommendations. And I would say that collaboration, thankfully, resulted in a paper, because I had to pilot test this, I call it advanced pharmacies delivered patient-centered care, to see what kind of impact did it produce. And my thinking then was, I want to generate evidence so that these people will stop being resistant to us. Like, we are really helpful to you, like we're making your job easier, so don't resist us. We don't do the same work. We have our distinctive roles, so we can still coexist in a very respectful manner. So that resulted to a paper, and this paper has been presented in 2 international conferences and really gained a lot of attention in terms of people wanting to know really how we did it. So just an example of how we can break through, even as we talk about, what to do in given the present situation of Nigeria. So I want to talk about the cultural gaps and the 80-20 rule. Really, I think that we don't need a dramatic change per se to make a change. And there are very little shifts that we can make, even just to our minds, that can lead to a big impact. And here I want to emphasize the importance of communication, because what I observed during my practice as a clinical pharmacist then was the fact that it just depends on how you communicate the intervention to the patient. I remember during our family training, we were told, do not query without providing a recommendation. So if you're querying and you're just saying, please check this, like, what am I checking? You're not even pointing out to me. But when you provide a recommendation, it empowers the person who you are sending that query to, be empowered to make the decision easily. So in order to make our work easy, we were asked to always provide recommendation, not just the query. So I realized that, and which was what brought me to this 80-20 rule, that sometimes for us to achieve our goal, which in this case is collaborative practice, we don't need like to showcase just our skills and certificates and degrees and all that. The 80-20 rule says we need 80% of those skills that we need are like the soft skills, and the 20% would be our real knowledge. So we need more of the non-pharmaceutical skills in order to break through into the collaborative space in our healthcare settings. So talking about soft skills like empathy, the language we use, being patient, with the providers. I remember one of the physicians that was very resistant initially, but I didn't react to that resistance. I was just patient, and with time, knowing that I'm not a threat, he came around, and we were able to, continue practicing in a collaborative manner. And then the communication. All of these outweigh the technical skills that we have, as well as the knowledge we have as clinical pharmacists or consultant pharmacists. So I just listed here talking about the language of collaboration. It's proactive listening, it's non-judgmental advocacy. And I gave some examples there just to, some of us may identify some things that we've been doing wrong, maybe not, and a better way to respond, for instance, saying this prescription is wrong. We can just say, oh, I noticed something that might impact the patient's safety. May I share my thoughts? And I just put all of that there. So I would want to say that belief, I think, is a very important component when it comes to how we are seen. If a pharmacist believes in themselves, I mean, we do believe in ourselves, and if this is seen through, I would say, the passion with which we put into doing our work, and we do it in a professional manner, and we show up consistently, we will become visible, and that will build trust in the system for us to be able to collaborate better. There is a quote here that I put, like, people resist what they do not understand, and the culture is shaped by our actions, not titles. This it doesn't come from a place of judgment at all. It's just saying that we can always learn and relearn how we do things. And I haven't read through a lot of documents Dr. Pounds have been sharing on the group. I've come to realize that although it looks like there is a systemic problem, but there are many things that we can do to be able to break through, to become better collaborators in all our spheres of practice. And that brings me to what I call the circle of concern versus the circle of influence. But I adapted this to fit into the the consultant pharmacist. So I call it like the consultant pharmacist mindset map. I first heard about this from Stephen Covey. Maybe those of us that might have read the 7 Habits of Highly Effective People, and I really, really like it. I always, use it in most of my presentations. So I feel that what we need to focus on right now is identifying what can we control and what can we not control, and focus on what we can control. So here, the circle of concern are those things that we have no control or no influence at all on. And the circle of influence are the things that the circle of influence that's supposed to be can. Are the things that we can control directly. We can't control directly, but we can influence through our actions and decisions. Okay, so that's called our power zone. A quote here from our group says, when you focus on what you can influence, your value becomes undeniable. And that's the truth. Like, based on what every other speaker have said, from Dr. Pounds making that incredible impact that led to breakthroughs for other pharmacy specialties. Here, I had listed some things that are in our circle of concern. What worries us, but we cannot directly control. So for this, the purpose of this audience, we have things like hospital structure. Oh, there is no formal pharmacist role in the words. You can put yourself there, right? Or you can just don't think about that or don't worry about that yet. Oh, there are no recognitions by interdisciplinary teams. The team dynamics are resistant, policy delays, there is bureaucracy, there is limited national funding and pharmacy-led programs. All of these are valid concerns, but if we dwell on them without a plan, it will lead to frustration, and the most important thing is for us to shift from our circle of concern to our circle of influence. Like, what can we control? We can control our attitude. We can control how we show up, being consistent, being positive, and professional. Our preparedness is another thing we can control. Being clinically sound, case ready, I remember sometimes I used to stay till like 9 p.m. with a team just trying to resolve a problem so that by the time the ward round team comes the next morning, they're able to see the recommendations and they're able to implement it for the patients. So our communication is another thing we can control. We can, learn to communicate more with empathy, clarity, and make all our dialogues to be evidence-based, because that way it cannot be denied. And also continuous learning. And with the advent of tools like AI, I am a big fan of AI. So AI can really help us to simulate any kind of scenario and solve any kind of problems. So we really need to start leveraging on these tools. So this is our power zone. And if we're able to focus here, and collaboration will follow. Not because of our titles per se, even if we go by the title consultants, but because of the value that we provide that will make us, in turn, impossible to be ignored. So I cannot overemphasize the role of mentorship and support. I received a lot of support from my head of department at the time to be able to do all of this, and even the consultant geriatrician, guidance, mentorship, even with what Dr. Pounds is doing. I wouldn't be here without mentorship and support. So I would want to say that we stand taller when someone lends us a shoulder, and I have a village of mentors, both in Nigeria and here, that have done exactly that for me, and I'm extremely grateful for that. So there's a saying that AI will replace the professionals, but there's also another quote that says, it doesn't come from anywhere, but we just say it often. AI won't replace professionals, but the professionals will use AI will replace those that don't. I'm just trying to advocate that pharmacists use AI now, not tomorrow, because it's not going to change. It's just like having resisting calculators. I learned some people resisted calculators the first time. So AI is just going to help us to expand that role and our influence in the healthcare space. And I just put some prompts there that we can use. Okay, this will be my final slide. I just want to say that start where you are. I think we can do anything from where we are. And the culture shift starts with us. In that little space of community practice or that little space of hospital practice, you can just start on the space, train yourself continuously, and let the impact invite collaboration. Also want to say that change begins with an individual, and a little iota of change will lead to a dramatic or systemic impact. Lastly, one of our quotes that says collaboration starts with visibility. Let your contributions speak so loudly they cannot be ignored. Thank you so very much. I'm going to hand it over to Dr. White now.
No, it will be to Dr. It's going to be to Lawal. Let her try to finish up.
Okay. Okay. Let me go back to her slide now.
I think she has one more slide.
Yes, one more. Yes, this one.
Okay. All right. So, Mrs. Lawal, please. Thank you. I think she's on now. She's able to unmute
Yes,
herself.
yeah. Thank you. So I was just taking us through a recent case of collaboration with a physician where this patient visited the pharmacy and the BP was somewhat alarming. So we called the physician, and the physician, we discussed the drug therapy that the patient was on before, which had a little issue, nifedipine and amlodipine. So we agreed to put the patient on lisinopril and methadone with nifedipine increased to 30 milligrams. They were advised to let the patient wait. We monitored the blood pressure at some regular intervals until the patient was stable enough to get to the hospital. So like Dr. Tari has submitted, there's a lot that we can achieve through collaboration, and a lot rests on us to adopt a lot of soft skills that will help us to showcase what we can bring to the table. And we also seize this opportunity to once more appreciate the role that Dr. Pans has played in our journey. Yeah, my team. We have some subscriptions that we learn from online. She got me into ACCP, and then the training that I'm having now, she's one of my key mentors to see me through that training. So all these trainings are preparing us and helping us to do more in terms of pharmacy care and work better with other healthcare professionals, so that together we're looking at, all of us have the interest of the patient. That's the truth. We all have the interest of the patient. So sometimes the problem is how we are communicating it. Like Dr. Tari said, when we get a prescription that seems odd, we don't go out to tell the prescriber that you have done wrong. I just say, oh, thank you for the opportunity to be part of this care. We noticed this and we cannot find any backing for it. We cannot find any evidence for it. This is the evidence that we saw. Is this deliberate, or would you want to look at? And more often than not, the reply will be, oh, sorry, go with this and go with that. So God will help us to accommodate ourselves, one another, and build more bridges so that we can work together in the best interest of the patient, which is at the heart of all of us healthcare professionals. Thank you, and God bless you.
Thank you. Thank you so much. I want to thank again our presenters for a phenomenal job. I think we've covered everybody. I know we started late. How much more time do we have? I think it would be good if we can at least give some time for people who have any questions. Correct, the moderator?
Yes, Ma. Thank you so much, Dr. Pounds. We're looking at if we can end by 11 o'clock. I think that would be good. 11 o'clock or at most 10 minutes past 11.
Okay, so how much time is that? Because we are in US time. So
Yeah,
that's
like 15 to 25 minutes from now.
okay, very good. Let me then quickly just say some housekeeping things quickly. The slides that are left has to do with the recommendations that we have. Some of the speakers probably, gave some what their thoughts and recommendations were. Now, this roadmap to moving forward could always be something that can be discussed with Dr. Maureen or anybody else, but it's a document. And that was something that I did the same thing and WAPCP a couple of years back, and they kind of took this information, and that's how they came up with the revised residency program that we're now piloting at Del Sud for the past 3 years. We're hoping to get it accredited very soon, maybe next year. So this roadmap was developed to really also look at acute care, what could be done in the acute care setting, meaning the hospital or the community. Mrs. Lawal already mentioned something pertaining to community, which is the collaborative practice agreement, all right? She's looking at that in her pharmacy. If there's any other community pharmacy that's interested and want to know what we're doing and want to pilot it in their area, please let me know. I am also piloting that in a clinic. I'm working with an infectious disease physician here in Atlanta, Georgia. And I have pharmacy students that come there. So we're looking at scaling up the clinical pharmacist involvement with her. And we will be looking at a collaborative practice agreement that we're going to be doing there. From the speakers, you already know Dr. White is very versed in this. So any one of you who are interested and want to talk about this offline after this presentation, please feel free. Somebody also asked about what that group that Terry keeps talking about. And I think that was at the first time that was the group that I said based on the interest that Mrs. Lawal had, she came to me, and based on her request, it became very clear to me that I needed to get a group of people together. The first two people I went to were Dr. White and Dr. Vivian Lau. And then Dr. Terry also had some things that she felt she needed to be mentored on. So I brought her into the group. And then, of course, Mrs. Lawal. So we're growing that group. So again, anybody who is interested, who wants to know more about it, please call me. So I think, everybody has my number and we can talk offline. So I think I would like to stop at this time and at least give you all time to ask questions. All right, is that okay here?
Yes, thank you so much, Dr. Pounds. Thank you, the great team, Dr. Vivian, Dr. Anisha White, pharmacist Folashede Lawal, and Dr. Tari Litz. Thank you so much for today's presentation. You've all done a great job. We've learned a lot on collaboration. We've learned a lot on the need for us to expand our practice and what the need for consultants in the healthcare profession. And you all gave very, very great insights from your different practice areas
from nutrition to critical care to community pharmacy setting, then to the pharmacoeconomics part of it with the challenges and how we can go about collaboration, and also the pharmaceutical health outcomes part of it. So I say thank you for what you have done for us today, and we believe that many of us would actually be able to put in what we've learned today into practice. So, but before there's a little bit of just little time we have for questions, but I would like to just quickly appreciate the presence of Professor Azuka Opara, one of our professors in clinical pharmacy. Professor Bolajoko Aina was also here present. Our Vice Chairman, Dr. Solomon Wafuru, our immediate past National Secretary, Dr. Motihat. I recognize your presence. And then I think now we can call on people to ask questions. Please, if you have any question, you can just raise your hand on the chat and you'll be called upon. Okay, I can see a pharmacist Luke Buckingham. Your hand is up. Go ahead and ask your question.
Okay, thank you very much for this wonderful opportunity for us to have this beautiful lecture at a time like this. I enjoy the lectures from beginning to the end. And we are talking about collaboration, which is very good. My question is this about the forms that we saw displayed, which is from the Community Pharmacist of Nigeria pertaining the referral form when you want to refer a patient maybe to a hospital because of the case you've managed. And in the case where you have a prescription from a doctor, mostly from hospitals, and you have seen clearly that there are some uh, prescription errors that you feel like this drug supposed to be substituted with another drug. Do we also have another form from ACPN with an ACPN logo and a letterhead, just like the referral form, where one can make such inputs and then put the suggestion that if the prescriber can consider these drugs instead of this because of this reaction or this interaction or things like that? Do we have something like that also in place? That's just what I wanted to find out. Thank you.
Okay, thank you, Dr. Luke. I think we'll take Dr. Ejiro's question so that both can be answered at once. Dr. Ejiro.
Thank you very much. Mine is not really a question. So I don't know if that's the question can be taken before I comment.
Okay then. Dr. Pounds, can you answer?
Yes. Oh yeah, I will refer that to, because he's referring to the practice, to Mrs. Lawal. Mrs. Lawal, please, can you take that question?
Thank you. Right now, we don't have, but it's something that can happen. And however it happens, we have to word it in the way that it will not be judgmental. So it's something that we need to work on. What we normally do for now, in my practice, we write letter with our letterhead, and we make it as appealing as possible. Thank the prescriber for the opportunity to be part of this management, and then we state whatever problem we have noticed, and then we deal with it based on whatever the problem is. But we don't go out to say you have made a mistake. No, we might just say we noticed this, and what we know in literature, and then we quote the references to say this is what we know should be, and that and that. So we will look at it. It's something that can be done.
Yeah, very good. Can I add one comment just for me, looking in from outside?
Sorry, Dr. Pounds, sorry, before you come in, can I say something as regards that, if you don't mind?
No, go
Okay,
ahead.
Dr. Luke, I think CPAN already has interdisciplinary forms that we have for our people to use. It's a documentation form that you can use to refer your patients to the physician. So it could be a patient that has come out of the hospital and comes to you, and you've noticed. It could be a first-time patient coming to you. It could also be someone that has actually visited a hospital and has come to you with the person's prescription, and you've noticed some errors. You could also use that form to send the patient back, or to now make a referral back to the physician in question. So I think it's something that could be used in various ways.
Okay, thank you very much, Dr. Bejuru. That's good. So maybe if this one will be within us here in Nigeria, if we can get those forms so that one can start studying and seeing if it is okay with those questions we've asked, it will be a very good step forward for us, because we have encountered some cases like that and there's no input and there's no collaboration you can do. You just have to tell the patient to ask the prescriber to consider this and that, and sometimes they never get back to you. So thank you for that.
Okay.
Okay.
Mhm. Okay.
Dr. Pounds, you're up.
Oh, no, yeah. No, I just wanted to say, to have it more, again, I won't know what your system is there in Nigeria, but we want to have something organized and structured, we're mainly standardized. I think that's where I'm getting at. If we want to have it standardized, whereby it's available to all the community pharmacists, will the procedure not be that you have an idea like such as this that Mrs. Lawal has shared? Will it not be that it will go through ACPN, which is a technical arm of PSN, and so that it can get up to that chain of command, and then the CPN, of course, has their own. So the CPAN, the ACPN, to get it to the group that would make it standardized and available for all the community pharmacists. I think that's where I'm getting at. Again, you have to talk to your leadership and see which way it has to go. But we need to start looking at, when we have best practices in Nigeria, let's try to get it whereby standardized, whereby everybody is doing the same thing. And that's one of the ways the perception of pharmacists will begin to change. In other words, other disciplines looking at us, like the physicians, the nurses, we need to start getting to that standardized format. That's the only point I wanted to make.
Okay, thank you, Ma. I think CPAN will look into that collaboration with ACPN, probably from the national level.
Yes.
Okay,
yes.
Dr. Ejiro, you're up.
Thank you very much for this opportunity, and I want to thank all those who've spoken for once again refreshing our memories and reminding us of our roles as consultant pharmacists. A very special thanks to my mentor, Dr. Teresa Pounds,
Oh, wow.
the lady with 9 lives.
Oh, thank you.
She practically nailed it. First, I want to say, while we may not be unaware of our roles as consultant pharmacists, one thing I noticed in the years of practice is the lack of a national strategy for collaboration. Now, we have individual pharmacists who excel in their various practices, like Mrs. Folashade, and a whole lot of centers. Dr. Tare gave instances of her center, and I'm sure many of us in this call have our own stories or examples of wonderful practices. In fact, when I went to UI for a pharmaceutical care in oncology training, the oncology pharmacists, they're in another level altogether. I also understand some other centers are excelling in other aspects of pharmacy. However, there is need for a national strategy where we have a standardized national care, national approach to pharmaceutical care, such that, for instance, the form Mrs. Folashade showed for my 14 years or 16 years in community practice, I had never seen that form. And it's an ACPN form. So some of these things there should be a system where all approach to pharmaceutical care is standardized so that if a pharmacist leaves one part of Nigeria and goes somewhere else, he knows that this is what is obtainable there. And having said that, there's need for in hospital practice to decentralize. Some centers are already doing that. If any of us here present have seen the current accreditation tool from PCN, as a member of that committee, we spent one whole week under the chairmanship of Professor Kunle from NIPRID to develop that document. And all the centers that have received PCN accreditation visit with that document to agree that the template is now there for hospital pharmacy to be at par, hospital pharmacy practice to be at par with any practice in the world. However, Professor Kunle raised the point. If they de-accredit any hospital for not meeting this standard, it is the same pharmacists that will complain. So there's need for self-evaluation. Are we ready to wear the big stick to make this practice become standardized? I also looked at the national prescription guidelines that have been circulating in the platform. And we see other professionals expanding their roles. But if you look at this section for pharmacists, it's a little limiting. Not a little, virtually limiting. We are not grabbing, as it were, or showcasing, expanding our roles, showcasing these specialized skills we are getting through our postgraduate training. So all of these are important for us to look into as pharmacists before we start blaming others. Now we have so many people with skills, but look at the adverts for pharmacists in any of our hospitals or our institutions. For each of these other professionals, you have different units or departments being advertised for. But when it comes to pharmacy, they just advertise for pharmacy. When you have different specialties, as it were, as consultants, even those who are not consultants, if you are decentralized and you have all of these units and you advertise for those units, that gives you numbers. And in our bureaucracy, it's a game of numbers in terms of leadership and policy direction. So a lot still needs to be done within our system to help us get to that level where at the policy or decision-making points, we have a voice. You can have wonderful skills in your various centers. Yes, the physicians then knows and they will use you. But when it comes to that national decision-making point, it becomes a problem. When it comes to where to be documented that this is your role, it becomes a problem because there are a few among them who are the power blocks. These ones are not ready for any change. So that is why we need to adapt. Like Dr. Tari made mention of the circle of concern and circle of influence. Well, for circle of influence are things that you can tackle immediately. But the circle of concern are things you need to have a medium and long-term strategy to overcome. And that is where our national collaboration as pharmacists in patient care in Nigeria is at this point. There's need for us to have a strategy in the midterm and in the long term to break this barrier. I want to stop at this point because time is valuable. Thank you very much.
Thank you very much, Dr. Ejiro, for your input. There's very little time now. We should be rounding up. Pharmacist Sheon, we'll just give you like 30 seconds to ask your question or make your input.
Okay, thank you so much and good evening, everybody. Thank you for the great presentation, Dr. Pounds. We cannot appreciate you too much. You've done so much and you're doing so much for pharmacy in Nigeria and globally. God bless you. So just a quick feedback. The last time from ACPN, because of the comment that was made, the last national executive of ACPN initiated some interventions that would look at community pharmacies nationally, assessing, credentialing, and in terms of quality assurance and improvement. And I'm glad to say that the current EXCO is actually working up on that. So very soon we should be hearing from ACPN in terms of service improvements, in terms of consultant pharmacies and the quality of clinical care that we provide in the community. And it's been being looked at from a national perspective, reviewed from a national perspective. So just to say that something good is being planned from ACPN, and very soon we should be hearing about it. Thank
Excellent.
you.
That's good to know. Thank you.
Okay, thank you very much. Dr. CNN, do we still have time? I hope you don't have a lot to say. Just 30 seconds, please.
Okay, good evening all.
Good evening.
Good evening.
Sorry, I don't know. I thank for the wonderful presentation or exposition today, but let me just rush because of time. I've just read out something. I wouldn't want to waste your time. I'm coming from the hospital background. I work in a tertiary hospital. One thing is that I want to kind of encourage my colleagues that are working in hospital that one thing, when we're talking about collaboration, I think one thing we should do is there are some ways we may do, because some of us may sit in our offices or whatever and expecting the physician to call us for collaboration. I think the physicians have gotten the stronghold. So most times it's we pharmacists that will move ahead. Like I suggest sometimes pharmacists can improve or establish this collaborative practice by joining the physician, trying to see how you can join the physicians during their presentation, clinical presentation, and nurses. When you go there and you begin to interface with them and begin to hear you, they will begin to look at you somehow and discover that you are not even there to attack them. They may even, over time, they will start inviting you. And again, sometimes pharmacy have their own departmental clinical presentation. I see no reason or something that I see no reason why we don't invite the physician. Sometimes we can invite some of these physicians. Come and join this our clinical presentation. Over time, they will begin to see, oh, these people are not in for war, that they're in for collaborative practice. And another thing I will want to talk, because most times when we are talking about pharmacists in the hospital collaborative, one problem we normally have in Nigeria is this issue of shortage of manpower. If you are understaffed where you are working, even as a consultant pharmacist, I don't see how long you may go. Then another thing I want to say, because of shortage of time, that's why I'm rushing. Sometimes I will advocate that, because it's not easy. Some hospitals are ahead of others. You will go to some hospital, you see where the hospital pharmacy staff going far. You will go to some hospital, you will see where the fellows and consultant pharmacists are even far behind. So it's not easy for you to just join the physician ward round, because you may go there and out of tension or fear, you may get yourself embarrassed. But I normally suggest, let us start with our own pharmacist own ward round. By the time you go to the ward, some people fear. Over time, you will remove fear. Over time, you begin to realize what you may do. And then before you talk about graduating to multidisciplinary round. Then another, the final word I want to say, just a contribution, is that sometimes we need to stoop low. They say you stoop low to conquer. When we are going on round or whatever, let us try to make our own round, not to be error finding word round. Let it be a kind of collaborative. By the time you begin to do some of these things, I think over time, some of these physicians that are hell bent that they will not allow pharmacists, over time, they will begin to even call you, hey, pharmacist, my pharmacist, come and do this or that. So let me just stop here. And I want to thank the organizer, Sepan and Co, for a wonderful job. Thank you.
Okay, thank you, Dr. CNN. Thank you all for being part of this presentation. Without the audience, there's no way we would have had a successful outing tonight. Dr. Pounds, do you have any final words for us, like closing words?
Well, I'll make it brief, maybe just 1 minute. I think the reason why I chose this format for this presentation is I wanted the opportunity for everybody to hear the different perspective. The only thing I wish I had time to go over because of time is the recommendation. But I think it's not too bad because I can always review that with your leadership, Dr. Maureen, and all that. But I want to say finally, though, that we should not be discouraged. What is happening here in Nigeria happened in the United States years ago. And I think Dr. White wanted to talk about that a little bit. And because of time, she really couldn't. So we evolved to where we are today. So that's what is going to happen in Nigeria. We are evolving. When I started coming to Nigeria to do what I do, I mean, where we are today is not what it was then. So a lot of positive things has happened, but we just need to keep working at it. A day will come that what is happening here in US in terms of physicians, pharmacists, collaboration, opportunity to see what's up will happen in Nigeria. I want to end by saying that there's also a value-based pharmacy project. Again, it's in the previous slides, last slides that I was, that we are piloting with Dr. Professor Larry Bale, Dr. Awosika, and about 7 community pharmacists who are involved in that. What is that about in a nutshell? That again is trying to show, we're going to be showing the value of pharmacists, especially right now, community pharmacists in providing clinical pharmacy services and also able to come up with a creative way of how they can bill for the services. You guys are also aware of what WAPCP is doing at Del Suit. And I'm glad Dr. Ejiro joined because he's one of the pioneer preceptors, whereby WAPCP realizes that yes, they need to have the opportunity for the residents to be more involved in rounding, working with the physicians, and so on and so forth. So that's going on. It's an international pharmacy practice residency program. So again, I want to thank our presenters. They didn't have much time. They did this because of me. And I feel blessed that I'm able to have touched so many people. And I will say, you all do the same thing. Touch others. God has blessed me, will continue. So let's continue to move forward and take care of this. The journey continues, but we're going to end well. So God bless. Thank you for the opportunity.
Thank you so much, Ma. Thank you, Tim, for a great job. Well done. Before I call on our national chairman to give us a few words, I want to specially acknowledge the presence of my own younger sister, who is a nurse and came to join us today to listen to us to really understand another aspect of what we've been talking about, consultant pharmacy practice. So she's here in our midst and she's a nurse with the Federal Medical Center, Asaba. Onyi,
really?
you're welcome on board. Yes.
Excellent.
Okay, so
Is she a member of WASPEN? She's in the hospital? Okay, that's good.
okay, I will need to find out
Okay,
from
no
her.
problem.
Though she's a public health nurse.
Oh,
So
public health. Okay.
yes, she's in public health, yes. Okay, Dr. Maureen for our national chairman, please give us a few words before we close.
Good evening, everyone.
Good evening.
Good evening.
I'm delighted this evening listening to all our 5 speakers, 5 in 1. Wow, how many hours we spent and we are still seated listening. Just want to appreciate all of you on behalf of our NEC members, all the members of CPAN. We want to thank our dear Mommy General of Clinical Pharmacy, Dr. Teresa Pams. What can we do without you, ma'am? We are very, very grateful for pulling these four speakers to speak to us. It's because of who you are. Ma'am, we appreciate you. Thank you, all of you, Dr. Vivian, Dr. Anesha, our dear family, Mrs. Folashade, and our dear Dr. Carole. Thank you so much for making that time to be with us tonight, showcasing what you know how to do. We appreciate all of you. I want to thank our dear moderator, Dr. Diaduro, for moderating tonight's clinical meeting. During the meeting, I saw our dear SIPAM Board of Trustee Chairman, Professor Zoko Opara. He was on this call. Maybe he's still here with us. So we are grateful to have you tonight. I want to also appreciate our Interim Education Committee Chairman, Pharmacist Former Mama. Thank you so much. I cited General Stella Ibe too. Ma, we're glad to have you tonight. And the Chairman SIPAM Mentorship Program, Dr. Dietrich. Thank you so much for what you are doing in SIPAM Mentorship Program. Okay, for me, I was glad when I heard that Dr. Vivian Leo is a critical care pharmacist. I am one too. So I would love that we collaborate more for our dear critical care specialty in a pharmacy. So I will know more of you. You are going to help us more here in Nigeria to really um, grow our dear critical care pharmacy specialty. Okay, yes, we spoke so much on building collaboration. I want to say that here in Nigeria, it depends on the center. For my own institution, my own units, intensive care units in UATH, we have a great collaboration with all the physicians, the nurses, everybody will work together as a team. And for us pharmacists, we do have our own pharmacist ward run, and we still join the multidisciplinary ward run every day. Is our protocol. So we still have such here in Nigeria, and I pray that other institutions will continue in that light. And I want to say that for us, we already started the anticoagulation management by pharmacists, and it's working. It's working. It's still another gap we are going to bridge in our practice here in Nigeria to really bring it up in limelight for all the pharmacists to join because it's our integral role. As we are managing antibiotic stewardship, we now have anticoagulation stewardship, and we've already flagged it up in our own center. So we have a lot to learn. I now pray that pharmacists should always join SIPAM clinical meetings. Okay, I heard Dr. Pan saying that she didn't have much time to talk about her recommendations. Ma will still give you another day for this. We're going to have another day later, at least even just one speaker or two to really summarize what we heard today. That will give us a good understanding because many people left when we must have spent so much time. Okay, so I don't want to start taking more time again. Thank you so much. We are grateful. Next week, we are going to be here again. Thank you, ma'am. Thank you, everyone.
All right. Thank you.
Thank you, National Chairman. Pharmacist Ifi Moma, Education Committee Chairman, can you give us your closing remarks? She's still here? I think I cited her. Okay.
Hello, good evening.
Okay,
Yeah,
good
I was having
evening.
problem with my phone. Yeah. Thank you very much. I really am very happy that I am in this presentation. I didn't even know I'll still be awake by now, but I was so enthralled. So I want to appreciate Dr. Teresa Pounds and her team, and the moderator. You really did well. I've learned a lot, and what stays with me said, be so visible that you cannot be ignored. So I want to encourage all of us that are here, like they've already encouraged us. that we should persevere, we should keep doing what we need to do. Don't bother so much about what you cannot control. Work on what you can influence. So with that, I want to say thank you very much once again. And that's it. Thank you. Thank you, Dr. Audu. Thank you.
Okay, thank you, Pharmacist Ife. I wanted to call on Pharmacist Hafsa Aminikoyi to give us a closing prayer, but it seems she's no longer here. Dr. Motihat, our immediate past National Secretary, if you're still here, please can you give us the closing prayer? Dr. Motihat. Okay, Pharmacist Ife, please still give us the closing prayer. Let's go.
Okay. In Jesus' name.
Amen.
Father, we appreciate you
Amen.
we thank you for the time we have spent. It's been so rich, so robust. We appreciate you. We ask, O Lord, for guidance, for wisdom. We ask you, Lord, for all that we need to do what we need to do. You are the one that made us consultants, made us clinical pharmacists, made us, professionals in our own rights. Since you have given us this mission, we know that you are also giving us the provision. We ask, O Lord, for the wisdom to do all that we need to do. As we each of us go to our beds, and the people in diaspora, maybe they continue with what they have to do for the day. We say, Father, that you stay with us, that you be with us, that you help us, so that this profession will take it to greater heights. In Jesus' name we've prayed. Amen.
Thank you all. Thank you, Dr. Pounds, Dr.
you,
Vivian, Dr. Nesha, Pharmacist Lawal,
Have a good
Dr.
night.
Tari. Good night, all.
Good
Thank you
night.
all.
Good night, everybody.
Good night.
Thank you. Good night.
Night.
Good night.
Bye.
Good night.